Hi, my name is Joseph Kurtz. I am currently a P3 student at DeUval College School of Pharmacy, and my journal club presentation is on the use of Drotrogan alpha in the treatment of patients with septic shock. The primary objective of the study was to determine the efficacy of Drotrogan alpha, abbreviated DROT-AA, in the treatment of patients with septic shock. DROT-AA is recombinant C-reactive protein, which is a crucial intermediary in inflammatory processes such as shock. So the primary efficacy measure was the percent or rate of patient mortality at 28 days. The study design was a double-blinded, placebo-controlled, multi-center trial. Basically, the experimenters or the study coordinators had multiple sites set up, and when a patient presented that was a possible candidate, a patient undergoing septic shock, the center was contacted, and then they analyzed the patient for inclusion and exclusion criteria, and if the patient met the criteria, then they proceeded with the study, randomizing and blinding Drotrogan alpha therapy, and then giving it to the site. So these subjects had to have a number of different inclusion criteria. This included diagnosis of sepsis, a diagnosis of shock, and a diagnosis of hypoperfusion. They also had to be 18 years or older and had to have presence of SIRS, which is a part of shock. Okay, the exclusion criteria was that the patient could not have received prior DROT-AA therapy within the past 28 days. The patient could not have internal bleeding. The patient could not have an INR greater than 5.0, and the patient could not have a pre-existing condition with a high rate of mortality. This also goes along the line with the exclusion criteria that the patient had to have a expected rate of survivability of at least 28 days, and this was obviously to avoid skewing the data. So the study period was 28 days with a follow-up period of 90 days. The examiners did not elucidate as to why they chose exactly 28 days for their primary endpoint measure. However, throughout the trial, the examiners alluded to a prior study in 2001 known as the Prowess trial. And the Prowess trial also analyzed the use of Drotrogan alpha in the treatment of patients with septic shock, and they found a significant improvement in patient mortality rates with treating with DROT-AA. And so my trial that was conducted this year in 2012 wanted to compare its results with the Prowess trial. And in the Prowess trial, the primary endpoint measure was 28 days. And so I believe that it wasn't exactly stated. However, I believe the examiners wanted to mimic the Prowess trial in order to directly compare their results with the Prowess trial. So the patients were monitored for mortality at 28 and secondary endpoint of 90 days. But the patients were also broken up into a number of subgroups, and this was also monitored. And this included their Apache 2 scores, which was the severity of the disease, the number of organ failures that the patients underwent while undergoing therapy, exposure to corticoid therapy, their ARD status, any recent surgeries, the protein C class, their endogenous protein C class, which I think is important to look at, and we can go into that a little bit later, and any recent surgeries, their prophylactic heparin exposure, and their coagulation SOFA scores. For tolerability, the patient or the examiners obviously monitored adverse events, and there was no statistically significant rate or higher rate of adverse events between either the DROT AA group or the placebo group. So that was in favor of drotrogan alpha. So the author's conclusions were that drotrogan alpha, DROT AA, actually posed no improvement on patient mortality rates. For the 28 days, we can see that the DROT AA group had a mortality rate of 26.4%, while the placebo group had a mortality rate of 24.2%. This was with a confidence interval of 1.09 and a p-value of 0.31. At 90 days, the secondary endpoint, the DROT AA group had a mortality rate of 34.1%, and the placebo group had a mortality rate of 32.7%. So this is a very minimal difference between the two groups. The authors also showed the numerous subgroups, like I had outlined before in the monitoring, and none of the subgroups showed a statistically significant difference in mortality rates between the DROT AA group and the placebo group. So the strengths of the trial were effective randomization, effective blinding. The conclusions had a direct correlation to the data. And I thought that the design, the stratification of the patients into the various subgroups directly identified patient populations that could possibly benefit from DROT AA therapy. So even if the septic shock patients in general, didn't benefit from DROT AA therapy, perhaps one of the subgroups could be identified that could, the Apache 2 class, or the number of organs that were failed, or the ARD status, or the protein C class. Interestingly, the protein C class, or endogenous protein C, which you would think patients would logically improve from exogenous recombinant C protein therapy, DROT AA, you would think they would logically improve. However, the examiner showed that there was no statistical significance in an improvement in patient mortality rates in DROT AA versus placebo. So I thought that this was interesting, that the authors elucidated this. Some of the weaknesses of the examiners were that I thought that they could have stratified perhaps the patients on different levels of inflammatory factors. There's a plethora of inflammatory factors that are involved in the shock process: prostaglandins, interleukins, TNF alpha, leukotrienes. I found it odd that the examiners had not done blood work to see what the status was of these markers of inflammation for the patients, and then also stratify the patients among those subgroups to see if any of them possibly showed benefit from exogenous C protein. I thought also another limitation was that there could have been slight bias towards disproving the prowess study. I'm not 100% sure, but it seemed that there was a general theme throughout the study that the prowess study was incorrect, or that the prowess study was wrong. So I didn't know if there was previous bias. However, I got the overall feeling that that could be happening. I also thought some of the limitations were that the study was funded by Eli Lilly. I couldn't directly correlate this in any way. However, it's always important to look at who is paying for the study. And I thought another limitation was that there was multiple sites, as this can always lead to the reporting of different results, as you have different conductors of the experiment at different sites. It could lead to slight shifting or skewing bias. So my recommendation is in concurrence with the authors of the study that DROT AA poses no real statistical significance in the treatment or improvement of patients undergoing septic shock. This was supported by their findings that there was no improvement in mortality rates in any of a number of their subgroups, and in the primary and secondary endpoints of 28 days and 90 days. I also could not find the exact cost of DROT AA. However, I saw many studies that alluded to the high cost of DROT AA, and it is only available brand name. So I thought that with the high costs of DROT AA, it did not offset with an improvement in efficacy. So that was important. There was no cost justification. And finally, this may alleviate practitioners' worries if they don't have DROT AA available to them, as this drug is available at some places, it's not formulated some places but not in others. So this is going to alleviate practitioners' worries that perhaps they could have helped the patients when really it showed no overall improvement in mortality rates. Thank you, and please email any questions you have to kurtzj21@dyc.edu. Have a nice day.